This is Katrina Anderson, and in this lecture I'll be going over some of the more common procedures that we see in primary care in women's health and clinic. So we'll talk mostly about pap smears, that's the bulk of this lecture, but then take a peek at colposcopy, when might we order ultrasounds, gonorrhea and chlamydia testing, how do we do wet mounts, how would we collect a herpes culture sample, and then what would be the purposes for doing urinalysis and urine cultures, what can we do with blood draws, and then just very briefly touching on birth control. So for the pap smear, you'll remember this from reproductive physiology, but we see here that the cells are initially made in the endocervix and they're columnar in nature, and like a grain elevator, they work their way down and then they come out, and then we have this transformation zone area where we turn from being columnar to squamous epithelium. So by the time we get to this yellow color, we're squamous epithelium. And this area in the middle we'll refer to as the transformation zone. And then that squamocolumnar junction is where you can very distinctly see the difference between the endocervix and when the transformation zone is starting. So we see this particular picture is a woman in her 30s. If you had a younger woman, then chances are you'd have more ectropy visible on her cervix. So these columnar cells might extend out further onto her ectocervix. Or if, say, you have a postmenopausal woman, then probably the columnar cells have receded even more. And that's protective. So the more HPV can be exposed to this transformation zone or ectropy area, then that does increase your risk for acquiring HPV. So just something to be aware of. Okay, so those are our terms. And then I just put this stat here that I think sets the pace nicely. 70%, there's been a 70% decrease in cervical cancer rates since the pap smear's initiation in 1950. So it's a very deadly cancer. It used to be the #1 cancer that killed women in the United States, but that number has gone down significantly, as you can see. And honestly, today, the women who are getting cervical cancer are women who've never had a pap smear, or it's been 10 plus years since they've had a pap smear. So very slow growing, but definitely lethal as well. I'm sorry, I have laryngitis, and I think that this is going to be my best day. So I thought I better record it today rather than waiting for tomorrow, but I'm sorry, you're going to have to hear me cough a little bit. Okay, so 48 hours prior to testing, as much as you can affect this, oftentimes women just show up and you don't have a whole lot of say over what they're thinking about before they come in. But you don't want them to douche, and really we don't want them to ever douche, but especially before having a pap smear. And then tampons can make the cervix irritable and inflamed, and so we want to avoid tampon use, not have sex, not use any kind of spermicide or really any kind of a medication in their vagina, and ideally mid-cycle is best. So how good is the pap smear? You can see here the sensitivity is a little bit all over the board, but is lower than our specificity. So let's just think through again what those terms mean. So a sensitivity is a true positive, as in if a woman does have cervical dysplasia, so metaplasia is the term for that normal change from columnar to epithelial cell. Dysplasia would be an abnormal change in the cell. So if you're having cervical dysplasia, if I do a pap smear, I'm able to detect it. So you have it and I found it. So positive test, positive disease. That's what the sensitivity is getting at. And then, so if you have it, I'm finding it. Where specificity is saying you tested negative and you don't have it. So that's a true negative. So if the pap smear is indeed negative, then that is reassuring to us. I mean, these aren't great numbers, but they're better than the sensitivity. So if it is negative, then chances are more likely than not we're good to go. We can keep moving forward. Whereas sometimes we have abnormal pap smears, and it's really not a cause for concern. So just to be aware. And then thinking about conventional versus liquid-based method. The conventional method is when you would collect your sample and then you would smear it on a slide that's then looked at under the microscope. And now I'm almost exclusively just seeing liquid-based for collection. And that's a pure form as far as the sample goes, because things like blood and mucus aren't going to interfere with seeing the cells, because they can essentially be weeded out just from it being exposed in the fluid. Another benefit to the liquid-based method is that you can test for HPV as well as gonorrhea and chlamydia off of your liquid-based sample, which is convenient. So I've already witnessed you all do excellent pap smear collection, so I won't get into this in too much detail, but just so that you're remembering the broom method, you swish around, or you go around 5 times, and then you make sure to swish it at least 10 times in your vial. And then that's a solo method, because that's getting ectocervical as well as endocervical cells, so we should have the full transformation zone there. Whereas the other method would be to use a spatula plus a brush. And the spatula is one full turn. You can see the longer end of that is touching into the endocervix, but this is what's collecting your ectocervical cells. And then the brush is put in until just those outer bristles are visible, and then you turn it a quarter to a half a turn. And then both of those involve swishing around 10 times. Okay, so interpreting results, you want to think about this as a ladder. So you could think of it as like a level 1 would be ascus, and then all the way up to, I'm just going to say, this high-grade squamous epithelial cell. So this is your ladder from the bottom to the top. And you can go up the ladder, and you can go down the ladder as far as abnormalities detected on a pap smear. So with ascus, basically everything above this first tier is going to be due to HPV, over 99-point-something%. So HPV is ultimately what's responsible for cervical dysplasia, unless it's cancer that has come to the cervix from a different part of the body. But if it's something that's starting at the cervix, it's going to be due to HPV. So with the exception of this first tier, that's true. Sometimes if people get the result of ascus, that could be due to chronic inflammation, maybe from tampon use or from recent infections like chlamydia or a yeast infection, that kind of thing. So anytime you order a pap smear, you can check a box that basically says, if you get an ascus result, go ahead and also test for HPV. So if you get an ascus result but then HPV is negative, then you can essentially ignore it. Whereas if you get anything higher than ascus, you can basically just assume that they are positive for HPV. So that's level 1 on the tier. And then the next level up would be ascus H. So basically there's a couple little scattered cells that kind of do look concerning, but it's not like we have a little clump of them, like it's an actual lesion or congregated cells that are looking abnormal, but just occasional random cells might look a little bit funky. That would be ascus H. And then LCIL, or low-grade squamous epithelial lesion, instead of scattered, it'd be like there's a little clump of cells that's organized into a pattern, but the degree of abnormality that they have we would consider to be low grade. Whereas with HSIL, or high-grade squamous epithelial cells, it's clumped into a lesion, but the cells look very altered, and it looks like it might be growing rapidly, or it has really dangerous changes associated with it. So that would be the high end. So you can see all of these are checking epithelial cells, so you're thinking more about the ectocervix, which is the majority of cervical cancers, whereas adenocarcinoma, sorry guys, adenocarcinoma would be glandular, or the columnar cells that are in the endocervix. And then if you do have squamous cell carcinoma, so all the way to here, then you, for the ectocervix, then it would specify if that's invasive or in situ. Generally speaking, though, you'd only be seeing things come up that are one of these first 4. That's the vast majority of your findings. guys. Okay, abnormal results. So, so like I said, you can go up the ladder and you can go down the ladder. So maybe you're LSIL 1 year and then there's a repeat PAP and your repeat PAP says you're fine. Or your repeat PAP says, okay, we've gone from LSIL to HSIL now. So if you don't do anything, 33% of squamous intraepithelial lesions will regress. So they'll recover fine on their own. About 41% will remain constant, and then in 25% of the time it will advance. So nearly 90% of women with detectable HPV infections will spontaneously clear it within 1 to 3 years, which is really important because young women, they have a lot of ectocervix showing, and then their lifestyle, they tend to have more sexual partners. Younger women are a lot more likely to be infected with HPV, but they're also a lot more likely to clear it, which is why we don't want to start testing women until they turn 21, because there's a decent chance if they're sexually active that they do have HPV, and there's a decent chance that there might be some cervical dysplasia. But one, they're capable of clearing that HPV infection, and two, their cells have such a higher turnaround that they'll clear both the HPV as well as the dysplasia, more likely than not. So it's extremely rare for a young woman for cervical dysplasia to develop into cancer. Okay, moving on. So when are we screening? So I'm going off of this chart that you can access via this link here, but it's looking at the ASCCP, United States Preventative Task Force, and then ACOG, all of them together. This is basically the organization for colposcopists, whose specialty essentially is cervical cancer. We'll talk about colposcopy in a bit here. So everybody starts at age 1. We all agree on that. Age 21. So age 21 is when we start PAPs. And then in your 20s, it's every 3 years. And in your 30s on, it can also be every 3 years. So you can even just think from age 21 to 65, every 3 years is a PAP smear. You can be done. Preferred method, though, would be that starting at age 30, you do your PAP, and then you also check for the presence of HPV within that PAP smear sample. So it's just an option for how you want your PAP ordered. You collect your PAP, and then you're saying, I want to check for HPV along with this. Or like I said, if you're in your 20s, you can say reflex to HPV if it's ascus. So that would be an option as well. So if you check for a PAP and you check for HPV and both are negative, then they're every 5 years. So that would be the preference, that starting at age 30, we space it out to every 5 years. But in order to do that, we need to test for HPV too. Again, it's such a slow-growing cancer that if HPV isn't even present, there would be no need to be PAPing that often. And then just something else to keep in mind as far as HPV goes. HPV is considered immunoevasive, which means that while I might test positive when I'm 25, and then over the next couple years it's no longer detected, it's not a concern if I'm not detecting it currently, but I might randomly, when I'm 52, have an abnormal pap smear that feels like it came out of nowhere, and I've had the same sexual partner for the last, 20 years. And that can come as a shock to people, but it's possible for HPV to just sort of fly under the radar for a long time. So we say that you have a really good chance of clearing it, and for all we know, we've cleared it forever, but there's always that chance that it might end up popping up again. So just something to be aware about with HPV. It's really more in hindsight to know if we've completely cleared it. But we can know if we have a current infection anyway, and that's what's more telling in terms of outcomes for cervical cancer at that time. So then when do we stop doing PAPs? You either stop doing PAPs at age 65, assuming they've had a good, adequate screening history. So, if in the last few years they've been having abnormal PAPs, then I wouldn't want to stop yet, versus if we've had a great PAP history for a long time, then it's fine to just go ahead and stop. Once you've stopped, you're never restarting. Also, if somebody has a hysterectomy where the cervix is also removed, then you should stop at that point as well. If they had it removed though because they had cancer, then you would want to think about just, you can kind of see like a pouch that's been, it almost looks like it's kind of stapled off or pinched off at the end of her vagina. If it's been removed, you can use like a spatula or even a brush and just scrape the cells near there. I see that mixed in the literature. That's not part of this chart, but I have seen that in the literature as a recommendation if cervical cancer is the reason that she has a hysterectomy. Otherwise, though, once we have a hysterectomy, we're done. Unless they left the cervix, in which case keep papping the cervix. Okay. These are the kind of guidelines that change frequently, so we want to stay up to date on those. On that note, how are we doing as midwives? So this is a study that was done in 2008, which is a little bit outdated, but the general principles we're doing right now would still apply here. So they asked OBs, midwives, and women's health nurse practitioners if they would screen this type of woman or not. And they had a bunch of different examples, but I just picked two. So an 18-year-old woman who isn't sexually active. One group papped 23% of the time, when 36 of respondents, I should say, 36% of respondents would pap, 74 would pap. So which group was the midwives? We were 36%. And then women's health NPs were the 23 and OBs were the 74%. So nobody, regardless of sexual activity, nobody starts getting papped until they're 21. Okay, second up, an adolescent within 1 month of onset of sexual activity. Again, nobody should be papped until 21. 58% was the women's health NPs, 70% was the midwives, and 95% were the OBs. You may find that you end up at a site that's not papping according to current guidelines, and that can be an area. Know that your preceptors are getting continuing education because they have you, partially because we're expecting that you're learning from them, but you're also bringing in the freshest information. My first site as a student, they were papping 17-year-olds, whether they were sexually active or not. And sometimes you end up in a place where you can make change, and sometimes you end up in a place where you can't move as much, but just something to be aware of. And also thinking about just our value as midwives. It carries over into women's health too. We think about doing the least amount of intervention possible. We're big cost savers all across the board, but especially we think about for pregnancy, but particularly birth care, right? We're a lot less expensive. We use a lot more we use less equipment, fewer interventions, etc. Papping everybody every year is expensive, and some sites are still doing that. So it wastes dollars. And then thinking about, especially young girls who are probably going to clear it on their own anyway, that's a lot of increased anxiety and a lot of increased follow-up visits. And then if they have procedures to remove portions of their cervix, that can affect their childbearing years down the road too. So thinking about, we'll get into some of those risks as we move on. But just that spirit of wanting to do least intervention possible carries into this as well. So what do we do if somebody does have an abnormal result? So really we need to go to the ASCCP guidelines. That's the colposcopy group. And I would highly recommend you get either the app or the booklet. If you have the app, then they'll keep, anytime there is an update, you'll keep getting the updates to your phone. Or the $7 booklet. 2012, yes, we change them a lot, but I suppose we could be due for another one, but I don't see a new change on the horizon anytime super soon. So I think that would even be worth it as well. I probably would have required it if I'd thought of it sooner, but that's the link you can go to purchase it if you would like. General principles would be anybody who's ever positive for HPV 16 or 18 gets a colpo. So Just as a refresher, we have about 100 types of HPV, and over 100, I'd say probably more like 150. And of those, about 40 of them affect women below the belt. And then of those 40, we say some are high risk and some are low risk. And the high risks are the ones that can lead to changes on your cervix, whereas the low risks are the ones that can lead to genital warts. And of the high-risk kinds, there's a little handful, but the vast majority of dysplasia is caused by HPV type 16 and 18. That's the one that Gardasil covers. So when you're testing for HPV, if HPV is positive, you can also have it reflex to test for type 16 and 18. So if ever somebody comes back as being positive for 16 or 18, that's an automatic COPO, regardless of what their cervix, like the cytology report says. And then ASCUS, there's more criteria for deciding what to do, but if it's L-Sil or up, then it tends to always be a colposcopy. But you really need to just look at the algorithm every time. So the algorithm is free. I just pulled over the web page that shows the free algorithm here. So you just go to the ASCCP website. You can look up what the most current guidelines are going to be. So you can just see here, this is what the booklet is, but it just has it in this form. So I wouldn't even bother memorizing it. I think it's good to have a general idea of how it trends, but more than anything, you just need to be capable of using the algorithm. I'd recommend getting it on your phone or having it in your pocket, but you can always go online and get it for free. So management of women who have L-Sil. So L-Sil, this is L-Sil with negative HPV test among women over 30 with co-testing. So that means that, she was 35, we did her PAP, and then we also just did HPV automatically because she's 30 plus, right? So she had L-Sil, but her HPV testing was negative. Preferred route would be to repeat test in a year. And then acceptable would be to just go straight to colposcopy. That's fine too. Or L-Sil where we didn't get an HPV test. Maybe you were on an every 3-year route road. Maybe that has to do with what your lab's capable of. Maybe it has to do with resources, cost, efficacy, that sort of thing. Not standard of care, but acceptable care, right? So if you don't know what her HPV status is, then you need to go to COPO. If she has a positive HPV test, then you also need to go right to COPO. So then you can see here, preferred would be repeat in a year. If in a year cytology is negative and HPV is negative, then we repeat co-testing at 3 years. So you can see it slowly gets you back on track with where you're at. So you can find this for everything. So this is, I just was looking at somebody's report and they're L-Sil, then I looked this up to see where we're at. Or here we have a pregnant woman who's L-Sil. Colposcopy is preferred. Here's management of women with ASCUS-H. Yep. So we see we're doing a colposcopy regardless of HPV status. So hopefully that kind of helps to I think it helps to kind of see how it's done so it's not as intimidating when you first look it up. So you can see American Society of Colposcopy and Cervical Pathology. All right, so I will minimize that, go back to our PowerPoint. Okay, so we're just going to keep going here. So reflex HPV testing, I've already touched on this a little bit, but you always want to get it in case there's ASCUS. So you say reflex in the event that there's ASCUS. So that way you can have more of a sense of, was this due to HPV changes or might it just be some kind of an inflammation issue? And then you might see something on there that says absent endocervical cells. So it will tell you if your sample was good or not. If you don't get a great sample, such as seeing absent endocervical cells, that can be a little bit more common in pregnancy as well as after menopause, when that transformation zone tends to pull up into the cervix a little bit more, so it's harder to get a full sample. So just to be aware of that. Okay, and then presence of endometrial cells in patients over 40. So it will comment, it might comment that they saw trichomonads, or they might comment that they saw endometrial cells. First off, if you see trichomonads, you need to see live trichomonads before you would diagnose that. So that would be worth having them come back in, but you wouldn't treat based off of something that they saw offhand on a pap smear. For endometrial cells, if it's a menstruating woman, you really don't think very much of it, because that's not surprising to see endometrial cells. If it's a woman with dysfunctional bleeding, or especially if she's past perimenopause and she's been menopausal for a while, so menopause is defined as your last period being a year ago, then that would be worth looking into to see about cervical cancer, or I'm sorry, endometrial cancer. And an endometrial biopsy would be the gold standard for diagnosing that, but that would be worth following up on if they saw that on a pap smear. So what does it mean to have a midwife as your primary care provider? I think especially thinking about how we handle abnormal pap results, there can be some significant anxiety over abnormal pap smear results. I think about some of the words we use, like precancerous lesion, or that ASCUS result has undetermined significance in it. That can lead to a lot of anxiety, where especially for a woman who's been married for years and they've both been faithful, or at least she's been assuming they've been faithful. I think hearing about HPV can really kind of send people through a loop. Mode of result notification, strongly encourage you guys, if it is an abnormal result, that you're calling personally rather than having like a clinic nurse just call back on all the labs. That one would be worth talking to your provider directly. Effect on sexual function, research has shown that can affect people's sexual function and satisfaction for up to 5 years after hearing about an abnormal pap result. So really our role is to lessen anxiety and depression, provide info on prevalence of HPV, and how ultimately there is a low risk of cancer, because we're just we're constantly checking in on where it's at, and it's so slow growing. And HPV, it's estimated that by age 50, 80% of women have had HPV at some point. So it's really, really common to have HPV, and whether or not that actually develops into cervical cancer, that part's pretty rare, but it takes really slow changes on the cervix to eventually get to cancer, and we're checking for those really, really slow changes. So colposcopy, we talked about how if it seems bad enough that we're not just rechecking in a year, we would send somebody to a colposcopist. So colposcopy is basically just putting in a speculum and then having a microscope so that you can see the cervical cells really, really well. So the organization I was talking about for colposcopists, 12% of their national members are advanced practice clinicians, nurse practitioners, nurse midwives, PAs. 6% of midwives are actually colposcopists as well. So this is something you could add on to your current scope of practice when you graduate, if that was of interest to you. And I will also say this is not hard, and it's a great revenue builder, and I think that's something midwives need to be really conscious of always. So, okay, so colposcopy, let's see what we're doing here. So it's a procedure for examining the vagina and cervix under magnification and illumination. So basically they spray a weak vinegar onto the cervix, and that vinegar dehydrates the cells and causes the abnormal cells to turn white, so that the lesion becomes more prominent and visible. And sometimes it can burn a little bit, but typically it's not uncomfortable. And basically, I'm giving this little spiel on colposcopy because I think it's helpful for us to be able to give some anticipatory guidance. If you see an abnormal pap, you're not just straight on referring them and letting them call and let them know there's an abnormal pap smear. we should be calling patients, we should be talking to them about the abnormal pap smear and roughly what to expect when they go to see the colposcopist. So generally then what's done, I'm going to actually go back for just a sec. So they spray the acetic acid on, and then let's say they see something that looks concerning. So this is what she sees. Okay, we need to take a look at that and see what's going on there. Then at that time she would take a biopsy. So you could have colposcopy literally is just looking at the cervix. Oscopy means to look, and colpo is referring to the cervix. So you can have a colposcopy without having a biopsy, but if they see something concerning when they're doing the colposcopy, then they'll get a biopsy. So some women report that this feels like a little bit of a pinch, or there's just no feeling at all. So this isn't a big deal. But they have this instrument here, which, side little free tidbit, I've used this same tool to get IUD strings out that I couldn't quite get with my normal clamps. When somebody wants their IUD removed, if their strings are kind of way up in their cervix, then I like to try to use this instrument. Anyway, so we use this instrument, alligator forceps, biopsy forceps, and it's like they take a pinch out of the area that looks concerning, and then that tissue sample is sent on to the lab. So a pap smear is getting a scraping of cells on the outer side, and those would be considered cytology results. Whereas here we're getting a whole tissue sample, so then that's histology results. So then let's look at what that looks like. Okay, so here I'll just say that again. Pap smear, cytology results. So ascus, L-sil, H-sil, etc. Colposcopy with a biopsy is histology results, which look like CIN1, CIN2. That's how it would look from there. So CIN1, if it's not treated, 1% will progress to severe dysplasia in a year. Generally speaking, this is more of a watch and wait. CIN2, 22% will progress to severe dysplasia or cancer within 5 years. Most pre-invasive cancers will develop into invasive cancer over a period of 10 to 12 years. So the CINs themselves aren't cancer, so this is the precancerous lesion piece. Cure rate when cancer is isolated is 90% versus 50% if it's invasive. So I think I said isolated, I meant localized, so that would be in situ. So if there's clear borders, cure rate's really good. If it's already invasive, then it's harder. Somewhat self-explanatory there. So again, this is a very slow-growing cancer. Okay, treatments. We are always just referring to our guidelines to know specifically what's best, but there's 3 general categories for treatment. There's chemically destructive. This is not widely used at all. Typically involves using acid. Then there's surgical ablation, which is cryotherapy, basically freezing it off. It's super, super cold. And then there's surgical excision, which could be a LEEP procedure or a cold knife conization. And basically everybody is going to be a LEEP procedure in the US. That's typically what you're going to see. Cryotherapy can be nice if you're, say, working in a developing country and you're not going to be able to see women for follow-up. They have an abnormal pap smear. Or I've actually even seen some trials where they're not even doing the pap smears, they're just giving people colpos, because this might be the only time someone looks at their cervix ever in their life. Say they live in a really remote area. But either way, you're spraying the vinegar solution on their cervix, and then if you see a lesion, you just freeze it off and you send them on their way. So that can be an intriguing way to do care if you're not able to have a lot of follow-up visits with women or a short time with women. So interesting research coming out on that. If anyone wants to do their research project on that, by all means pick me to be your tracking faculty. Okay, so then I'm just going to get into these 3 just a little bit more. Again, chemically we don't really see used very much. So cryotherapy, it'd be like you have one of these instruments, and then that instrument is attached to a gun, and then frozen nitrogen is running through the gun, not out the gun, but through the gun to make the end of this really, really cold. So you can see that being done here. It would just be pressed right up against it. I'm going to be really cold. This one looks like it is actually squirting out the nitrogen. But usually I hear it referred to as just really making the instrument cold. So frozen nitrogen freezes or destroys tissue at the top of the cervix. It can be hard if it's too large of a region, but picking which instrument you use can help with that. And then women tend to have a watery discharge for 6 weeks or so from just continued cells dying and shedding off. So not seen very much, but now you at least know roughly what it's about. Oops, sorry. Okay, so surgical excision. This is the one you will see the most commonly. So we call them LEEPs, which stands for Loop Electrosurgical Excision Procedure. High success rate with a generally low recurrence rate. So you have this instrument that's like a loop, and then there's electricity running through the tool. Patients will have at least some form of anesthesia here, and the electricity is running through this loop so that basically it's like they are scooping off the end of the cervix, which you can see here. So that's a LEEP. Okay, and then one thing that's nice about this versus cryotherapy is then you actually have something you can send to the lab and they can give you a better idea if you got it all. So literature is kind of mixed on this. Possible risk for future preterm labors, incompetent cervixes, low birth weight babies. So it's a little bit mixed, but there's definitely a risk if you have it done repeatedly for those things. But this is a generally quick and easy procedure, and if you're comparing potential for preterm labor in the future versus cervical cancer now, then probably we're going to go for a LEEP. Okay, and then the other one would be a cold knife conization, which is the same concept as the LEEP, but you're using a scalpel. You can see that there. Generally done in a surgical center, higher bleeding rates than if you did a LEEP procedure. And higher rates of second trimester abortion. So again, pretty much you'll see a LEEP. So say you have a woman coming in, this is her first annual with you, and she says, oh yeah, I did have an abnormal PAP. It was about 5 years ago. I would say, do you remember if what kind of an abnormality it was? Do you remember the words ascus or L-cell or H-cell? Usually I get a no. Which I would encourage you, if your women do have something, that we are teaching them the language around it, because that is part of their healthcare and part of them owning their healthcare and being able to communicate it to future providers. But then I'll say, oh, okay, well, did you end up having a colposcopy? And if nothing else, that gives me a rough sense of what degree it was. And then they'll say, yes, perhaps. And then I'll say, do you remember if they ended up getting a biopsy? And they might say yes, but then that was fine. I think that's probably most commonly what I hear. Or they'll say yes, and then I had some kind of a procedure, and I'll say, was it a LEEP? And they'll say yes, and then they'll say yep, and then all my PAPs have been fine since. So just for getting a decently good medical history, those are the kinds of questions I would want to know around this. Oh, and there's one more on the cone biopsy, so that's the cold knife again. They're just pretty much trying to nip out the whole transformation zone there. Okay, so let's go from there to endometrial biopsy. So colposcopy is something that you would need additional training for, though it's not a lot of additional training. It's like going to one of the long workshops and then working with a local colposcopist for a while. So very, very doable. And I think the more we can keep revenue in our office, I think midwives are always suffering a little bit for keeping their head above water cost-wise. So realizing that we can be offering services in an excellent way and be able to keep some of that revenue in-house is always a great idea. And I think it's also so great for women who trust you and you're in their care and they know you. And maybe you've caught their children, to then say, hey, we have an abnormal pap smear and let's just make an appointment and I can do the colposcopy. That just feels like such a safer environment to have to then navigate a new healthcare system or a new clinic, etc. So really nice for continuity. Okay, endometrial biopsy. This is something that you could do even now, even though that probably sounds a little bit scary right now. So this is absolutely going to be within your scope of practice as a midwife right from the get-go. So indications would be like abnormal menstrual bleeding, or if you have a woman who's bleeding after menopause, or maybe even absence of uterine bleeding. You can think about both biopsies as well as doing ultrasounds to kind of see what's going on. But for endometrial cancer, getting an endometrial biopsy would be the gold standard. So it can detect infections. So if we think somebody has an infection, then we're not doing this, because especially say she had vaginal chlamydia, this procedure could pull the chlamydia from her vagina into her uterus. That's not what we're wanting to do. But it can detect infections when it's looking at when the lab is looking at the tissue sample. And then it could also detect polyp tissue or fibroid tissue, and then endometrial cancer is most typically why we're doing it in the first place. So contraindications would be an infection or pregnancy. So risks or side effects. The main side effect is going to be pain. It's really uncomfortable to have something in your uterus. I say this the same for IUD insertions. If we put something inside your uterus, then your uterus is going to try to cramp it out. So it feels like intense menstrual cramps. And then once it's out of your uterus, very quickly your uterus feels fine again, but it can feel really uncomfortable while you're having it. So having them take NSAIDs 30 minutes to an hour before the procedure can be a little bit helpful. I'm speaking about this to IUDs as well. For IUDs, putting it in is particularly uncomfortable, and then once you take out the inserter, it's a lot better, but then they tend to still feel crampy for the next couple days because you did leave something in their uterus, right? So your uterus is going to try to cramp it out. These risks would be the same for putting in IUDs. So bleeding, infection, uterine perforation. The bleeding can be due to uterine perforation, which is rare. Or you put a tenaculum on the cervix, and that can sometimes lead to a little bit of bleeding after the procedure as well. So we're going to set this up similar to an IUD, which is what you guys will look at more in depth next week, and you all have your kits. But basically, we're inserting our speculum, and then we're cleansing our cervix. That could be like a betadine pack where there's 3 Q-tips inside that have a betadine solution on it, and you just start at the inner os and work your way out. Make sure you're covering the area where you're going to apply the tenaculum as well. So doing that 3 times, and then you can apply the tenaculum. Generally speaking, if their uterus is anteverted, then you'll put it at the top, versus if it's retroverted, you'll put it in the posterior cervix. And I'm wondering if you know what a tenaculum is. Pause for just a second. So here's an example of a tenaculum. So it's kind of like, I think of it as like little pinchers on the end. So you can apply that to the anterior cervix and then pull back on it, and that'll give you a little bit of traction to help straighten out the uterus. So you'll put the tenaculum on, and then you'll sound the uterus, which is basically putting in a small thin rod that's sterile, and you put it in as far as it'll go, and then you can see how far that measures, so you know how far in your uterus is. So pretty commonly it's somewhere in the 6 to 9 centimeters from the external os of the cervix till you've hit this fundus. So that's important for both IUDs as well as endometrial biopsies, because we don't want to put our instruments in farther than that point. So we've sounded our uterus, we know how far in it goes. And then for doing an endometrial biopsy, you have a suction catheter. So basically it's this thin tube, and then there's this other rod inside it as well. And this rod would be squished in when you go to put it in. So then you put it in all the way till we've hit the fundus, and then you pull this back, and that creates a suction within the uterus. And then what you do is, you can see here with this twisting motion, you just twist the rod back and forth in your fingers, kind of like you're rolling a pill in your fingers. And then while you do that, you're moving this in and out of the fundus. So you need to do that. You don't take it all the way out, because if you take it past the cervix here, then you're going to lose your suction, right? So you just keep going back and forth while you're spinning. And then basically there's 2 little holes at the end of this catheter, and the endometrial tissue will start suctioning into the holes and down here. So you can kind of see in this picture, it's like there's a red substance up to here. So that would be all the endometrial tissue that's getting sucked into your catheter. So you're moving it in and out, and you're twirling it, and you're going in and out at least 4 times. But you can also see how much tissue you've got. So keep going until you've got a good sample, a good amount of tissue in there. And sometimes people will come all the way out, empty out what's in here, and then they'll go back for a second pass too. But I think it's kind of, it seems like a much more sterile procedure if you can get it in one. Okay. So we're not removing until we finish, and then you're withdrawing, and you see that it's full of tissue, and then what you can do is put this back in, and then it's like it will squish all of the tissue that's in there out those 2 little holes again. So you can squish it back into your collection tube, and then you can send it off. Okay. And again, you can absolutely do this, and I think that kind of stuff is a little bit scary until you start to get into it, but especially once you've put in a few IUDs, this is not that much bigger of a deal. But you do need to be intentional that you're not putting it in deeper than what you sounded to, because that would be the main risk here, is that you accidentally perforate your uterus. So gentle, and then doing the best you can to help prep her pain-wise, because that is not a comfortable procedure. Okay, pelvic ultrasounds, we're evaluating the uterus and the ovaries. Indications would be pregnancy. We can do it early on in pregnancy to do dating. Mid-pregnancy, we do a full-blown anatomy scan. This is stuff you would send people out for. A biophysical profile or an amniotic fluid index. All of those can be done in pregnancy, and you would be the one ordering them. Just as a midwife could become a colposcopist, a midwife can also be trained in limited ultrasound, in which case you could do a dating ultrasound, biophysical profiles, amniotic fluid index. That would be within your scope at that point. But when you first graduate, ultrasound is not in your scope, but easily acquirable should you want to. So reasons for doing this: abnormal uterine bleeding, particularly if menopausal. And you can see here, this is her vagina, and then this here is her uterus. And then here you can kind of see a lighter shade of tissue here in the center of her uterus. We call this her endometrial stripe. And that can actually be measured, and that's looking at endometrial growth. So, you know, we have multiple layers of muscle and whatnot that comprise the uterus, and then this endometrium is what we grow and shed every month, right? So we can measure how much growth is there. So especially if somebody's postmenopausal, that can be very helpful in detecting if there's too much growth there. In which case, if there was, then you'd want to do an endometrial biopsy, because that would be your gold standard for thinking about endometrial cancer. So pelvic pain, ovarian cysts, ectopic pregnancies, that could be another reason to do a pelvic ultrasound. It could be part of an infertility workup. If you have a woman come in who has an IUD for 2 years and she can't find her strings, and you put a speculum in and you can't find her strings either, you can send her to get a pelvic ultrasound, and they can see if they can find the IUD in her uterus or if it's elsewhere. Okay. And then better for infertility would be a hysterosalpingogram would be an option for a full workup. This is when you would put in a dye, and then you then do the x-ray and can see if if her fallopian tubes are patent. So maybe she's had a history of chlamydia twice, and all the little cilia lining her fallopian tube are dead, and they're scarring, and if the dye can't get through, then that would explain that her fertility would be cut in half, right? So that would be an example of when you might order a hysterosalpingogram, or in this case, this is a bicornicate uterus that can be detected. So just different things we have in our toolbox. Okay. Gonorrhea and chlamydia. We want to be screening high-risk women and women under 25. And you have a couple options. You could use a GenProbe or an NAAT for testing. And there's 3 different places you could get it. So you could do an endocervical collection. So you would insert the swab 1 to 1.5 centimeters into her endocervical canal, and then you rotate it for 10 to 30 seconds, and then you withdraw it without touching the vagina or anything else, and then you're done. Or you can do a urine sample, and if you do this, you don't want it to be a clean catch. We're wanting a dirty catch, right? So we're not doing midstream, we're not wiping first, you're just peeing into the cup, and then that's what we're sending to the lab. Typically, you pee in a cup and then you transfer it to a tube, and that's what we would send. The tube would either be the GenProbe or the NAAT. And then vaginal collection, patient can self-collect or you can collect it, but basically you're inserting the Dacron-tipped swab at least 2.5 centimeters into the vagina, and then you're rotating that for 15 to 30 seconds. And then if somebody is positive, you're repeating this test after treatment, 3 months if they're not pregnant, 3 to 4 weeks if they are pregnant. So wet mounts, I have you watching a video on this too, so I won't get into too much detail here, but basically this would be collecting a vaginal sample. Usually it'd be like just take a plain old Q-tip or the cotton tipped applicators you have in the office, and you can look at just dip it into the vaginal discharge that's in your posterior and lateral fornices. And at that point you could put it in a little test tube and send it on its way, or you could, and if you did that, then you would be you're not just using any cotton tipped applicator, I should say that, you're using a specific test for it. But if you're going to look at it yourself, you just get the cotton tipped applicator, and then you would get 2 slides out, and you'd scrape what you've got on your cotton tipped applicator on both your slides, and on one slide you're going to put a drop of KOH, and on the other slide you're going to put normal saline. And then add cover slips to those, and those are ready to go. And then before you discard your Q-tip, I would check the pH by smearing a little bit more of the vaginal discharge onto a pH strip, and then also add a drop of KOH to that. I think of doing that just over the garbage. And then you smell it, and if it smells super fishy, that's a positive whiff test. Okay, and then you go back to your slides, and you're looking at them under both 10x and 40x, and I think of it as like doing laps on a swimming pool. So if this screen was my slide, and it's like I'm going all the way down, and all the way down, all the way down, covering the full area where I smeared my sample. Okay, so we've done that, and then what might we find? So we talked about the whiff test. If it smells super fishy, that's consistent with BV or possibly Trichomonas. If it has a high pH, that's more consistent with BV, or bacterial vaginosis, I should say. Clue cells are also consistent with BV. I'll show you a picture of those. Live trichomonads, and again, we need them to be live, so you need to see them swimming. If they're dead, that doesn't count. And those ones like to swim to the edges of your slide, so that's why you really do need to scan the whole thing. And then yeast buds and hyphae. Oh, I should have put, this is the KOH slide. Let's put that in right now. So basically KOH, that's your second slide. That one you're just looking for candidiasis. So if you put KOH on a slide, it breaks up all the epithelial cells, everything else on that slide, so that all that's really left is your yeast buds and your hyphae, so it's easier to find them. So you could find yeast buds and hyphae on your saline slide, but it's a lot harder to see it. So that's why we do the KOH slide. And then you could chart this like wet mount, pH is 5.0, positive whiff, positive clue cells, negative buds and hyphae. That would be very consistent with bacterial vaginosis. So here's clue cells. So this would be like a normal epithelial cell, and then this one, it looks like it's peppered with bacteria. So here I would say, see how you can see the edges really nicely on this epithelial cell, versus here it's it's fuzzy, and it looks peppered. So that's our clue cell. Okay. And then here's yeast buds and hyphae. So the buds are usually there in little clumps of two or more. And then hyphae or pseudohyphae are like so. And then here's our trichomonads, and then you would see them swimming. Oh, I should have found a YouTube for this. Well, you can YouTube that if you would like. But it's like they have little flagella here that you usually can't see on the slide, but they would be swimming. So remember what those look like. And then if you needed to get a herpes culture, that's going to be gold standard if you're needing to diagnose herpes. What you want to do is, well, so first of all, you can also check serology, but that's not really telling you if the lesion you're looking at is herpes or not, right? That's only telling you, yes, this person is a carrier for herpes type 1 or type 2, but it doesn't speak to what you're actually looking at. So the key for getting a culture here is you need it to be juicy. If these lesions have kind of scabbed over, chances are you're not going to be able to get a good enough sample to have it be positive. So the sensitivity, the chance that we have a true positive, very much relies on us being able to get a good sample. So the earlier on in the infection, the better. So basically you just need to get the fluid. So you could do that one of two ways. You could get a tuberculin syringe and just gently poke it and drain out a little bit of the juice, because basically the vesicle discharge, that's where all the viral load is that we're wanting to detect. Or you can use a Dacron tip swab and kind of scrape the edge off and then use your Q-tip to soak up the juice, or rub back and forth with the Q-tip to get some of the discharge there as well. And then that's what you're sending off. And there's a lot of different brands. I didn't get into that in depth in this slide presentation because a lot of it just depends on what lab you're using and what your clinic's preferences are. But you would need a GG assay, which basically once you get set up and comfortable in a clinic, then I think that's worth having a little mini tour of what you do for labs there. So you know what to grab. Okay, urinalysis we're probably all pretty familiar with. Ideally, we've got a clean catch. What matters most is that it's midstream. So you're instructing them to pee a little bit and then catch their urine until you have an appropriate amount, and then they can pee the rest out into the toilet. So it's midstream, and you can either dip it in the office, which is what I have pictured here, or you can send it to the lab to get the report. So if you dip it in the office, then you're just looking at the case that the dipstick came in to see roughly what color's matching to figure out what the pH is, etc. Main things we're looking for would be leukocytes, so white blood cells, nitrites, which are a byproduct that bacteria give off, or blood. All of those could be consistent with a UTI. And then thinking about pH, glucose and ketones, and then protein, especially in pregnancy. Not that we do it routinely, but thinking about preeclampsia. So a urine culture is going to be your gold standard for a diagnosis of a UTI. However, if you have a woman come in who's very symptomatic of a UTI and you dip it in the office and you're seeing positive nitrites and positive leukocytes, then probably you're going to want to start to treat her and then send this urine for a culture, and then you can have the culture verify what you're already doing or make sure that the antibiotic you chose was appropriate, etc. So that's urinalysis, and then for a urine culture, basically it's like they've got it in a petri dish, and then each of these is little antibiotics, so then they can tell which antibiotic is so if you look at this one, this antibiotic was very good at controlling the growth, versus this one not so much, this one not at all. So then you'd get a report that looks kind of like this. I'm just going to blow it up here. So it says that it's E. coli and that there's greater than 100,000 organisms per milliliter. So that's what you need for diagnosis, is whatever it is, it's more than 100,000 organisms. If you see there's more than 100,000 organisms and they're saying that there's multiple types of bacteria, then probably you've just got a bad sample. And unless they're symptomatic, Generally speaking, you're just going to move on with your life and not worry about it. We would do a urine culture on every pregnant woman at her new OB. If that one came back over 100,000, but 3+ types of organisms, then we would consider that negative and move on, that it's just a contaminated sample. Okay, so then susceptibility results, we see all these different antibiotics are listed here, and then it's put whether it's sensitive versus resistant, whether the E. coli is in our dish. And so if we haven't started treatment yet, then we could use this to help give us insight into what the best antibiotic would use for treatment. Okay, blood draws. So we'll get into the specifics of exactly what you're drawing and when you would draw it and how you would do follow-up, but just to be aware that all of these things are things we might commonly be testing for. So HIV, syphilis, Hep B, all of those are part of a routine new OB lab draw. Typically people that offer water birth will also do Hep C as well. Cholesterol, thyroid hormones, checking for anemia, vitamin D, I think those are probably the top 4 that I do within women's health. And then beta HCG, you could do whether that's urine in somebody's new OB if you're wanting to verify that they're pregnant, or like if you're worried about miscarriage, then you could be tracking their HCG. So urine would just be it's positive or it's negative, right? But if we do serum, then we can actually track exactly what their levels are quantitatively. So say a woman is having some cramping and some bleeding, but maybe she's just bleeding. Let's say she's bleeding in pregnancy. You can draw her beta HCG, and then you can draw it again 2 days later. And for the first 6 weeks of pregnancy, we would expect that that level would about double. So, you know, if it's, yes, having a really high number versus a lower number is encouraging, but really it's the trend that matters. So say she was 90,000 one day and then 2 days later she's 100,000, that's a very slow rise, or maybe it's gone down. That can be helpful for thinking about miscarriage management. And then finally, just a note on, so long as we're saying women's healthcare procedures, to be aware that probably the most common ones we're doing are birth control related. So most midwives I know do quite a few IUDs. Well, here's a tenaculum in place, so little pinchers on the anterior cervix there. So IUDs, inserting implanon, that's something you would need additional training for, but that's quick and easy after you graduate if you want to be at a site that does Nexplanon insertions as well as removals. And then diaphragm fittings are kind of on the out, but we'll get back into that week 4 in both pharmacology and women's health. We're talking about contraception. And then next week for this course in Nursing 714, you will be thinking about how to put in your IUDs. So get your kits out and start practicing. Thanks for hanging in there with me, and I'm so sorry that I coughed my way through the whole thing. All right, have a great week. Welcome to spring semester.